now. Good evening, everyone, and welcome to the latest in our Understanding Health talks. Very glad to welcome you all, and thank you very much for joining us. We're delighted to have Mr Mevcha, who'll be talking to us tonight on understanding the prostate and prostate cancer. Before he starts, a few words, if I may. Please, if you've got any questions during the talk, please place them in the Q&A bar. And what we'll do is that Mr Mevcha will be looking at these questions as we go along and may answer them during his talk, or some of them he may wait until the end and we can answer them all together at the end. So please do place your questions there. Please do remember that keep the questions as general as possible, so not about personal issues, etc., because we won't be able to answer them, and you don't want to be sharing your personal details on a public forum. But any general questions would be much appreciated. This talk is one of a series that we do, and one of the benefits of becoming a member of the Trust, we have many members, is that you hear about these talks in advance, which is fantastic, and also we send links so that you can actually watch any talks that you've missed after the event. Members also get a few other benefits. They get a magazine called Together Magazine, and also this includes details about how to become a governor, for instance. Governors are a vital resource for the Trust. So lots of information in the magazine about that. And also details of our future plans. As many of you know, we've got big plans for East Dorset, about a major emergency hospital and a major planned care hospital. So this includes a lot of details about that. Also includes details of our future talks, and for instance, our next talk is Understanding Fibromyalgia on Wednesday the 27th of April, so you can hear all about that. But anyway, you're not here for that, you're here to listen to Mr Mevcha, so without further ado, I'm going to hand you over to him. Thank you very much, Mr Mevcha.
Thank you very much, James, for introduction, and hello everyone. I would like to welcome you all today on behalf of the Trust to this Understanding Health event, focusing on prostate cancer today. This month is also March for Men, and it's celebrated as Prostate Cancer Awareness Month. I am one of the 11 urologists within the department here, and I do have a special interest in prostate cancer diagnosis and also treatment aspect. Two of my other colleagues shares a similar sort of interest. But as I said, we are a team of 11 consultants, and we all see the patients concerned or worried about prostate cancer. And together with the team of doctors and nurses, and in a partnership with Primary Care Trust, we all design and deliver prostate cancer care in line with national guidances, but also tailored into individual need. So my declaration of interest, I'm a practicing urologist and employed by UHD. I'm not tied with any pharmaceutical companies or anything. So what are we going to talk today? It will be all about prostate, but focusing mostly on prostate cancer and symptoms which may be because of the cancer, what kind of investigations you may have if you are worried or concerned about prostate cancer, and what are the treatment options available within the Dorset if you've been diagnosed with prostate cancer. So what is prostate? It's a small walnut-sized gland which is just underneath the bladder in the pelvis area in the man. This is another schematic diagram. So this is a bladder, prostate, and the water pipe passes through it. Precise function is not fully understood. We don't know, but we know that prostate produces and secretes lots of fluid, which becomes a part of the ejaculation or ejaculate, and it also allows sperm nourishment. On top of that, prostate produces protein, which is PSA, which you may have heard about it, which is the blood test everybody have when they are worried about prostate, and it stands for prostate specific antigen. So we are here today is because prostate will come into next slide. It's quite important. It's affected not just because of the cancer, but also by so many benign conditions. Almost all men will have some effect at the later in the age as the prostate start enlarging. And it's absolutely normal for prostate to enlarge with age. And here in the diagram, if you see, this is a normal prostate, and with the age, prostate start enlarging and it compresses the urethra or the water pipe. And most of the time, it's just a benign or age-related enlargement of the prostate, which affects on the inner part of the prostate, and that can give you trouble with waterworks, difficulty in passing urine, and passing urine more often, or urgency as well. In some cases, it can cause urinary retention where you are not able to pass any urine at all. But prostate can also be affected by infection and, of course, cancer. And what is prostate cancer? So it's an uncontrolled growth of the cells of the prostate. So our normal physiology in a normal body, as the cells get older, they are replaced by the new cells. But here, the growth becomes completely uncontrolled, and prostate glands start getting bigger. Usually starts in the outer part of the prostate. So, as I mentioned previously, that benign enlargement is in the inner part of the prostate. The cancer usually starts in the outer part. It can affect in a small number of cases or small percentage of cases into the inner part as well. Cancer itself is dependent to male hormone testosterone. And when the cancer starts, it usually is confined within the prostate. But it can also, it does have a capacity, especially the aggressive type of cancers, which can spread outside the prostate. And if you look at the numbers, prostate cancer is very important in a way that more than 50% men are getting diagnosed with prostate cancer every year in this country. And it's the commonest cancer in the man in the UK. With increasing life expectancy, about 1/3 of men we diagnose with prostate cancer are 75 or older. And prostate cancer grows very slowly, and it usually may not give you any problem or unlikely to spread outside the prostate as well. So what are the risks? As I said, there are increasing number of patients are getting diagnosed, or people getting diagnosed with prostate cancer. And that may be because the PSA blood test or prostate blood test is widely available and used widely by surgery, GP surgeries, anyone in hospital. And when you compare the numbers of PSA blood test started somewhere in 80s, but now we are doing more and more tests every year, and lifetime risk of developing cancer is about 1 in 6 to 8. The risk of developing cancer in the prostate increases with age. So usually starts from over the 50. There are some incident data suggests that even in people who are in 30s and 40s, they can have indolent cancer. So if you take a samples and look under the microscope, you may find a cancer within the prostate. It's not giving any problem. We know older you are, higher risk of getting a cancer within the prostate. Afro-Caribbean community is highest risk of developing prostate cancer, followed by Caucasian and then Asian. Prostate cancer is very uncommon in Asian countries. However, if those people migrate to any European countries, then after a few years, their risk of developing cancer also increases, and that led to the theory that whether there are any genetic background or environmental factors, or whether anything in the diet which can stop you developing cancer in the prostate. And there are lots of studies been done looking at the diet and the nutrition, and most common elements, it's lycopene, selenium, vitamin E. Lycopene is a substance that you get from the tomato, and sometimes in pomegranate as well, but so far we do not have any clear evidence that whether those substances help you to reduce either a risk or prevent you to develop cancer. There's also family history is also very important in prostate cancer. So if you have one first-degree relative affected with the prostate cancer, especially at the younger age, in 50s or early 60s, then your risk of developing cancer increases. It's twice as high. And if there are two family members, then risk is 4 times. And there are some genetic factors been identified, same as in breast cancer. So it's a BRCA gene, which can also lead to increased development of prostate cancer. There are some evidence coming out that if your BMI is high, more than 30, and then you may be at slightly higher risk of developing prostate cancer. And there are also certain hormones like insulin, like growth factors, which regulates the cycles or life of the cells inside the body. And if those levels are high, then there is also some indirect evidence that the risk of cancer in the prostate is higher. So moving on to symptoms, if somebody has got prostate cancer, what kind of symptoms they may be experiencing? Well, it's not really any symptoms which is caused by prostate cancer directly. As I said, prostate cancer usually develops in the outer part of the prostate. And in small proportion, when it grows into inner part, yes, it can give trouble with the waterworks, like urgency, difficulty, or frequency, but not necessarily it's coming from cancer part. It could be just age-related enlarging or benign enlargement of the prostate giving you symptoms. Similarly, blood in ejaculation, blood in semen, or in urine are most likely coming from the benign enlargement of the prostate rather than a cancer. However, when the prostate cancer is advanced, you may experience some symptoms, but it depends upon where the cancer has spread to. And that can be, if it's spread to bones, then you may have a bony pain, like a back pain, tenuous pain. You may be losing weight, you've lost your appetite, you're generally feeling unwell. And if cancer is affecting lymph glands within the pelvis, then it can give you swelling within the legs. So to diagnose prostate cancer, what happens? There are lots of tests, and there are tests which is done by GP, and usually it's a urine test, PSA test, and DRE, it's a digital rectal examination, which is an examination the prostate from the tail end. And once a GP has done all these tests, then it's been assessed whether somebody needs to come to the hospital and need to be reviewed or seen by specialist. And when you come to the hospital, you probably will have some more tests. It could be repetitions of the tests that you had, like blood test, urine test, examination. But it could be some radiological tests like a CT scan, MRI scan, and even biopsy of the prostate. So this picture is just showing at the bottom how we examine the prostate gland. So we can feel the prostate gland, usually the outer part, and that's where the commonest site of the cancer to occur through the tail end. But it's still not 100% test. There is no one test which will give us an absolute idea if there is a cancer or not. So it's a combination of tests that have been used. So PSA test is a simple blood test. Before you decide to have a PSA test, it's worth having a discussion with your doctor or the nurses in a surgery or even to a specialist, because PSA alone, it's not the diagnostic tool, because the PSA, as I mentioned previously, it's a protein which comes from the prostate and then released in the circulation. And it's been produced not by just a normal prostate, but also by cancer cells. And PSA level can be affected by other things like infection in the waterworks. It can raise your PSA in even tens and hundreds. If somebody has done rigorous exercise or ejaculation, even examination of the prostate, somebody had a catheter, which is a rubber tube inside the bladder to help them pass a urine. All these things can alter your PSA reading and can give you falsely high reading. There are certain medications which can shrink prostate gland, and they tend to bring the PSA reading down. So somebody on tablets like finasteride, which is a prostate shrinking tablet, and if you've been on those tablets for 6 months or more, that means the reading will be about a half of what normal is. So when you're seeing the specialist or when you're seeing your doctor, they would correct those readings. And they're aware that, yes, you are on medication, so readings are different. Other test you can have is a radiological test, which is an MRI, stands for magnetic resonance imaging. This test usually use magnet and radio waves to create a picture of your prostate. There is no radiation involved. However, you need to have a certain checks or safety checks before you can have an MRI. Certain metal in the body can react to these radio waves and magnet, like somebody has got pacemaker. So not all the pacemaker are MRI safe. So you will have a safety check before you go for MRI scan. And what MRI does, so it looks at your prostate in electromagnetic field, and give us lots of idea. It may not tell us exactly if there is a cancer or not, but it can pick up in areas which looks different than the age-related growing prostate. It can measure the size of the prostate more accurately. And it can give us an idea about whether the PSA reading and the size of the prostate matches or not, which is called PSA density. Because if somebody has got larger prostate, they are probably having a high PSA reading. And the prostate, I usually say it's like a second fingerprint of the man. There are no two prostates same. We know that prostate enlarges, but it's not like at same pace, same size in each and every one. So it's a very different. It's very unique to individual. Somebody who are on active surveillance for prostate cancer, who are just having it monitored regularly rather than having any active treatment. Even those patients can have regular MRI scan just to keep an eye whether anything is changing inside the prostate or not. And when you have an MRI, this is kind of a room that you go through, and it's a tunnel. So people who are claustrophobic, we try and avoid them, but sometimes sedation can help. And as I said, there is a rigorous check before somebody goes through this scanner. And once you have an MRI scan, it's been looked by X-ray doctors or radiologists. And when the radiologists look at MRI scan, they can tell us, they can give a reading. It's called a pivot scoring. And the reading is from 1 to 5. Now, when it says 1 and 2, that means unlikely somebody has got prostate cancer. Or unlikely it's a significant cancer which needs any treatment. When it's 4 and 5, then it's likely there is some prostate cancer which will need treatment. And when it's 3, they're not sure what exactly is happening. Again, radiologists are very clever doctors, and they tell us with their experience as well that whether we should do a biopsy on somebody. And MRI can help us to see whether we need to do biopsy, because if MRI results are more accurate, then we can avoid putting somebody through unnecessary biopsy and any side effects that somebody can get it through. I'm getting some questions here. So one of the questions been put in is how quickly can prostate cancer spread? So it's very slow growing cancer, so it doesn't spread very quickly. It takes months and years before it starts spreading, provided the cancer's been identified only in the prostate in the beginning. Another question, can medications taken for other conditions or an infection elsewhere in my body increase PSA? So yes, it can. And I think it's a stress related response that body experiencing. So we know somebody has got chest infection and they may have a PSA reading suddenly shot up. So any stress your body experiencing, we do come across that PSA reading rises as well. So safest thing to do is repeat PSA a few weeks later on. So once you have MRI scan, then you may go for prostate biopsy. And so prostate biopsy is obtaining samples from the prostate using needle. And then pathologists look under the microscope. And it gives us so many answers. It can help us to find out if there is a cancer or not. And if there is, then what's the nature of the cancer? The biopsy is usually performed by ultrasound probe under the guidance of ultrasound probe, which is placed in the back passage. And the biopsy can be done in 2 different ways. Either the needles can pass through the wall of the back passage, or needle can pass through the area called perineum, which is the area between the legs. If MRIs can identify any pirates 3, 4, or 5 area, which is in the front of the prostate, then we would usually recommend somebody to have a transperineal biopsy because it's difficult to access it from the transrectal approach. And in current situations, we are doing biopsy both under local anesthetic or general anesthetic. Of course, it carries the risk of bleeding and infection and even sepsis as well. In very near future, we are hoping to start a new biopsy technique. It's called precision point. And this is the technique where all the biopsy is done through the transperineal approach, and the risk of infection and sepsis is virtually zero with this. And we can take a lot more samples as well without any pain or discomfort. So this is a TRUS or transrectal ultrasound guided biopsy. If you can see, the ultrasound probe is placed in back passage. Local anesthetic is filtered around the prostate, and the 10 to 12 samples are taken from the different part of the prostate. And when the pathologist look under the microscope all these samples, as I said, it can give us an idea whether there is a cancer or not, but more importantly, what kind of cancer. And so cancer is given a Gleason score or groups. And Gleason score is the very common and widely used system to grade prostate cancer. And when the grade, there are 5 grades, 1 to 5. Grade 1 is the least aggressive form of cancer in the prostate, and grade 5 is the highest grade or most aggressive. And Gleason score is how the cancer cells looking very close to the prostate normal cells, and those scorings are given 3, 4, and 5. And we get the combination of 3, 4, and 5, and then we divide them into the 5 different groups. So group 1 is Gleason score 3+3. So even cancer cell looks very similar to the normal prostate cells. And these are the type of the cancers which grows very slowly, if at all. And as we go up in the group, the Gleason score start changing, 3+4, 7, and 4+3, 7, which is different. We always say that 4+3, 7 is worse than the 3+4, 7. But the group 4 and 5 are high-grade cancers usually. So what happens in locally in University Hospital Dorset? So, if you have seen your doctor, GP, and you had a blood test which shows that your PSA reading is high, or your prostate, when it was examined, it doesn't feel smooth, or it feels very hard or lumpy and bumpy, then your doctor will refer you to us, and you will see one of the urologists. Sometimes you have a scan, which is an MRI scan, before you come and see us in a clinic. And once you come to the clinic, you may have further tests like another blood test for PSA or urine test. And we'll discuss your MRI results and decide whether you need a prostate biopsy or whether you can have safe PSA monitoring. So as I said, if somebody's MRI gives a scoring of 1 and 2 and PSA reading is acceptable for the size, prostate size, then there is probably chance of finding cancer in a prostate on biopsy is very small, and it's better to avoid those complications and instead continue to monitor the readings. And some of you might have come through the department and you might have seen different consultants, registrar, and cancer specialist nurses. Once you have all the tests done, all the results are reviewed in one of the multidisciplinary team meeting. We call it MDT meeting, where we as a urologist are there, but also we have a radiologist who have a special interest in looking at the prostate MRI scan. We have a pathologist who is re-reviewing the prostate biopsy results. We have plenty of nurses and oncologists who are the cancer specialist doctor. And as a group, then we discuss, is it a cancer? What kind of cancer it is, and what kind of treatment options we can offer somebody. So for example, if you go through all the tests and let's say the outcome is that there is no cancer been identified. So what's going to happen? So likely it is that we'll recommend you to continue having PSA monitoring. And that monitoring can be done either with us or with the GP. And if you're having it monitored in the community, then we have given a guidance to GP that if PSA reading goes to a certain level, then you need to come back to us and we may have to repeat test. And let's say other scenario, if we have found cancer, and again, you will be seen by clinic, by a consultant or registrar and cancer specialist nurses. And depend upon the nature of cancer, if it's a high grade cancers or if your PSA reading's been very high to start with, then you may need further test like another MRI scan or a CT scan looking at your chest, tummy and pelvis again, or a bone scan to look at the bones in whole body, or a PET scan, which is again a radionuclear test. And we are one of the few centers in the country who do have an access or a facility to do PET scan. So depending upon the type of the cancer PSA reading, you may have one of these tests to check for any spread or the extent of the cancer. And once we have those results, then we can say whether the cancer is localized or contained within the prostate, whether it's locally advanced or not. Locally advanced cancer means it has started to break out of the prostate or just outside the prostate in a lymph gland within the pelvis as well. Or whether it could be an advanced cancer. Advanced cancer means it has spread to the other parts of the body. And the system's been used, it's called TNM staging. So when you come to the clinic, this is what we are discussing. It's about the diagnosis that yes, there is a cancer, but also the grade and the stage. And then we discuss about what are the treatment options available for you. And when we decide on any treatment, treatment for prostate cancer depends upon what's your age when you've been diagnosed with prostate cancer, what's your general health, how fit you are, what other health related conditions you suffer for, or what kind of operations you had in past, but also the grade and stage of the cancer, and then of course your preference. So let's see what happens if somebody has got localized prostate cancer. Now, when somebody has got localized prostate cancer, and if it's a low grade, then we tend to recommend active surveillance. The reason for that, we know that this cancer takes years to get worse or start giving any problem, or it may not give any problem at all. So active surveillance means keeping a very close eye on the PSA reading regularly. And what we are doing is not just keeping an eye on the cancer, but we are also avoiding any unnecessary side effects from the treatment that you can get. Other options are surgery, where you have complete prostate removal, which is called robotic radical prostatectomy operation. And we've been doing it with the use of robot. So it's a robotic approach, so it's a keyhole approach. Other treatment options are external beam radiotherapy. It's like an X-ray treatment, so you don't need any operation. It's an X-ray that kills the cancer cells. And I will come on to a bit later on, but these treatment options, they are all equal in terms of controlling cancer. It's not that one is superior than the other. There are certain situations where we would probably recommend one option or favor one option rather than the other. And it depends again on your age, prostate size, type of the cancer, and that's all what we discuss in clinic. There is a low dose rate brachytherapy. What it means, it's radioactive seeds are placed inside the prostate, which delivers the radiation to all the cancer cells and it kills it. And there is also high dose rate brachytherapy. That means you have a radioactive seeds put in, but it's taken out and it's not permanent. But you have an extra treatment or extra treatment from outside afterwards. These are all recommended by NICE, National Institute of Clinical Excellence, national body. You may have heard about other options, other treatments like freezing technique or cryotherapy, HIFU, which is an ultrasound energy which been used that kills the cancer, hormone treatment, and sometimes watchful wait. So if somebody at older age been diagnosed with prostate cancer, which tends to be very low grade and may not give any problem for the rest of their life, rather than doing any treatment, we just say we can monitor the PSA reading, and if somebody develops symptoms, then yes, we give them appropriate treatment. And these were all for localized prostate cancer, which is a cancer confined within the prostate itself. This is a robot. It's an intuitive surgical exercise system that we are gonna get now, and this is how it's done. Surgeon is away from the patient and controlling the robot. All these arms are inside, and it's a keyhole approach. So somebody who do have a robotic prostatectomy usually stays just overnight. Recovery is a lot quicker. Chance of blood transfusion or risk of needing blood transfusion is very small, but there are very specific risk of having surgery like urinary incontinence, usually temporary, and erectile dysfunction. Compared to localized, if somebody has got locally advanced or very advanced cancer, then there may be a role for surgery in very selected patients. But usually it could be a hormone treatment which contains or controls the prostate cancer. And there are also chemotherapy. And there are lots of new hormone treatments coming out now. And we have it available locally as well. And there are lots of trials been running, so you may be a part of the trial. So in summary, prostate cancer is the most common cancer in men. If you are worried or concerned about the prostate cancer, then have a discussion with your doctor or specialist. Talk about whether you need a PSA. Look at your ethnic background. Check family history, see whether you are at higher risk or not. All the investigations and the treatment, which is recommended nationally, are all available locally. So if somebody decide to have a surgery or needs a surgery, so it's surgeries or operations done at Bournemouth Hospital. Somebody needs a radiotherapy or brachytherapy, that's done by cancer specialist doctors or oncologists, and that's been done at Poole Hospital. And we are at moment planning to develop a one-stop clinic. So if your doctor refers you to us with high PSA reading, then you have all the tests done, possibly in in one go, in one day. So you can have MRI scan, you see the specialist, can possibly have a biopsy, and then next time when you come just for the results and discussion. So that's a work in progress at the moment. Yeah, I would like to thank you all for your attention and listening and giving me this opportunity. I'm gonna look at the questions. I think there are a few more questions that have come through. So question is there a national screening program? So I'm just gonna highlight it. Is there a national screening program for men for prostate cancer like bowel cancer? So currently there is no prostate cancer screening program, and the aim for screening is that you want to find out early signs of cancer before even you develop any symptoms. And as I mentioned before, that prostate cancer not necessarily have any symptoms itself. And with the screening, you have to give this important that benefit of screening program actually outweighs the disadvantages. And there is no one test which can give us a 100% answer. And there have been lots of trials been done in past about using a PSA as a screening tool for prostate cancer, and it hasn't shown that PSA is a useful tool for prostate cancer screening. Now, lots of research been going on. It's not just about PSA, but now combining with MRI scan, and there are other cancer markers like urine markers and some genetic tests. But as of now, there are no screening program because PSA is not that great test to look for prostate cancer. The next question is, if prostate cancer is treated successful, is it likely that it will return? So the short answer is yes. However, it all depends upon what kind of cancer. If it's a localized contained within the prostate itself, most of the time you only need one treatment. The longest follow-up data we have got, it's somewhere about 15 years, because after 15 years, there is not much follow-up data available in literature. And after any treatment, we expect your PSA to become almost undetectable. So somebody had an operation, in about 6-8 weeks time, PSA reading will be almost zero. Somebody has a brachytherapy or radiotherapy, it will take some more time for PSA to become undetectable, but we know there is a tendency that normal prostate cells can start regrowing and your PSA can become detectable afterwards or start rising. And we would never know whether it's coming from the cancer or whether it's just normal prostate cells enlarging or growing. But we always say that it's because of the cancer. So yes, PSA can become detectable, or you can say, yes, cancer is coming back, but whether you need a treatment, that's a whole different question, and chance that you may not need second treatment. So yeah, even after one treatment, cancer can come back, but very small proportion of patients would need a second treatment. I think that was the last question. So thank you very much. I hope you have enjoyed, and try to reassure you that not to worry too much. Of course, if you are worried, then we are always here to help you. Thank you.
Fantastic. Thank you so much, Mr. Mevcha. Just to pass on our thanks as well from the audience and from the Trust. That was a really enlightening talk and very interesting, and I think will have helped sort of people with their concerns, etc. So really appreciated. And just to say again, we'll be sharing the recording of this and also details of becoming a member of our Trust are available on our website. So just to say thank you all for listening. Thank you for sending in your questions. Really appreciate it. And until the next Understanding Health Talk.